Okay, we are live.
So, Sagar, can we start?
Yes, please go ahead, sir.
Yes. Good evening, everybody. On behalf of IRI Gujarat State Chapter, on behalf of Dr. Mukesh, Dr. Sir, our President, and myself, Dr. Gaurav Goswami, Secretary, I would like to invite the eminent faculty of Society of Oncoimaging, President Dr. Bhagyam Raghavan, Secretary Dr. Pankaj Sharma, and Academic Coordinator Dr. Sudhir Kale. Dr. Bhagyam is HOD Apollo Cancer Center and practicing in Chennai, and she is a teacher of so many of the students like me and a few of my colleagues, and she is one of the pioneer of Society of Oncoimaging Society in India. Dr. Pankaj Sharma sir is a professor in AIMS Rishikesh and intervention radiologist, elder brother, mentor, and one of the finest interventionist of India. Dr. Sudhir Kale sir is practicing as a lead head radiologist of Esther Medical Services. He is right now practicing at Bengaluru, and he is taking care of this SOII Academy. I would like to hand over this session to Dr. Pankaj Sharma sir to brief about SOII academic activity and the this today's collaboration between IRI Gujarat State Chapter and Society of Oncoimaging. Over to Dr. Pankaj sir. Sir.
Thank you, Dr. Gaurav, for nice introduction. First of all, on behalf of Society of Oncoimaging India, SOII, I welcome you all, and I thank the Gujarat IRA, especially Dr. Murgesh and Dr. Gaurav and the entire the Gujarat IRA team for this wonderful collaboration. And so, Society of Oncoimaging is a society of onco radiologists practicing in India, and Dr. Bhagyam is president, and I am secretary, and we welcome you all. I will hand over the podium to Dr. Sudhir Kale, who is the academic coordinator for the SOII academic activities, and this is the first initiative seminar of the SOII this year. So welcome, Dr. Sudhir.
Hi, thank you so much, Dr. Pankaj. And I think really we are very thankful to Gujarat State Chapter for making us start this SOII academic activity. So thanks to Dr. Gaurav and Dr. Murugesh. And as you know, we have our dynamic president and secretary, Dr. Bhagyam and Pankaj, Dr. Pankaj with us. I mean, always behind and encouraging for the academic events. So the SOII Academy intent is to create a good channel of people who are with similar kind of thinking, and we will start this as an academic program in a series of webinars. So initially, to begin with, we thought we'll start with PET-CT, then followed by we'll have a lot of other systematic things like structured reporting, or it can be a resist, and we can have a series of panel discussions. Maybe we are thinking intent is to go zonal wise, or maybe we can have inter-societal meetings, and then we can have some international faculties and experts coming and joining us. So I think this is a wonderful platform for all of us. As you know that learning and education is a continuous process, and oncoimaging is in the forefront of innovations, and a lot of new developments keep happening. So it's very the only just an annual or a midterm CME doesn't suffice. So we thought that we'll make this as a continuous learning activity over the entire year, and to just kick off the session. I mean, we have two eminent speakers today, Dr. Bhagyam Raghavan and Dr. Murli Krishna. So today it's going to be the session on PET-CT. So the first topic will be taken by the Dr. Bhagyam. So all that glitters is not gold. I mean, she's a great presenter, and you can see the next 45 minutes to 1 hour. I think she'll really, you'll see really nice input and nice set of cases. Over to you, ma'am.
Thank you very much. And I would like to first thank IRIA Gujarat and the secretary and the president, Dr. Gaurav, who's also a key member of our Society of Oncoimaging. We are starting this event And as Sudhir has already told, that it is going to be, it's start of something better of SOII Academy. And we know that every question in a DNB or an MD, you have onco imaging. So that is something, and and it has become one of the commonest cancers that we are having, and imaging becomes the bulwark of it. So today I just thought that, PET CT is so important, and we need to, because that without functional imaging, it's just a dead body, what they say, no, it's not without morphology, it is just a ghost. But without functional imaging, without function, it is a dead body. So we do not want both these. We don't want a ghost, we don't want a dead body. What we want is an active, live, imaging body which we can diagnose and help patients. So there are two parts to this. I thought I will just give a brief overview, and then and the normal variants and what are the common problems we have. And then Dr. Murli Krishna will take over and talk about the Secretary of IRIA will take over the rest of, and add it as a case presentation. So now we all know that when we have PET CT, the reason why PET CT is really unique is because it is able to give two positrons in opposite directions. So what in SPECT imaging and all was a 2D image, you are now able to recreate a 3D image. Okay. And 3D functional image. CT, we always had a 3D image, but in nuclear medicine, we never had that until PET CT came. And for that, you needed an isotope, which is a positron emitting isotope. And that, what happens is, when it releases two positrons, and then you have a positron and electron, which gives rise to two 511 keV gamma ray. Okay, so that is the reason why why it is very important for us to. That's where it made a huge difference. And when you fuse PET CT with the three-dimensional image that you can get from the by positron imaging, you are able to fuse it better, and you are able to do the 3D reconstructions and all that. And we know that for every isotope that you do, which is you have to have a ligand. Here you are using FDG. So 18-fluorodeoxyglucose is the main isotope. And we know that the glucose pathway is it's one of the key pathways at any cellular level. So and in fact, brain, majority of the metabolism, the whole body, it is the glucose activity. And we know tumors take up glucose avidly. They need to grow fast, and they're highly metabolically active. So we do need to bind it with deoxyglucose. So isotope is F18, half-life is 109.8 minutes. They're substituted for hydrogen atoms and incorporated in glucose as FDG18. So 18-fluorodeoxyglucose, 10 to 15 MCI. But when you have the newer models, time of flight imaging, most of the time we are doing just 5 millicurie, and that is injected as IV. And we do have now even digital PET, which is able to predict and show us much, much better imaging. Now, how do we go about this? So here you can see this donut is the CT. So when the patient goes in, he first has the CT. Then after that, he goes through the PET, and there are 6 bed positions, and each area is scanned. CT happens in a jiffy, as opposed to PET, where you have to take it in 6 bed positions. So fusion imaging is after resting for 1 to 2 hours, the whole body CT is done, and then you have the PET. Now, earlier when they just had PET, it never really took off. Addition of CT made a whole huge difference in how we are able to do cases. In fact, in India, we actually, a lot of times abroad, when they have the algorithms, they prefer to do a CT and then they do a PET. But in our setup, it is more wise to do the whole body PET CT, where we're able to get the diagnostic information as well as the metabolic information. It's important, as I told you, the whole thing rests on glucose. So serum glucose must be less than 200 milligram. It should be or ideally should be 150 milligram per DL. And the patient should be fasting for 4 to 6 hours. Serum creatinine is a must because we are giving CT contrast. We are doing a diagnostic level CT. Sometimes they do low dose CT where you don't give contrast. But in our setup, we do not want the patient to come once, go again for an abdomen CT, this, that, and then come back for the PET. So once you have a clinical high suspicion, also a lot of times we have inflammatory conditions, infective conditions like tuberculosis and all that. So we do just go ahead with the CT itself. And then you can also, it is important to catheterize a patient, particularly in bedridden and incontinent patients, so that the urine doesn't soil the image. Okay. So as I told you, morphology without function is a corpse, function without anatomy is a ghost, and fusion is the best. So the radiation, if you talk about it, the CT component is very high, but it becomes an inherent part of a PET CT because we need to do an attenuation correction. And when you do with CT, it is done with CT so that you remove the background activity, the skin activity. So the CT component acts as a very important part of the I would say calibration of the study, so that, or pre-calibration, so that it happens. First you calibrate, have the isotope, then the attenuation the machine does by itself and gives you the values. So because of the radiation involved, most of the staff will have to, we have to shield them. FDG eluting and mixing is done. Drugs are given in a very shielded environment. And then after injecting, the patient is kept in a warm, quiet room with little stimulation, as speech during uptake is associated with increased FDG uptake in the laryngeal muscles. And then it is important to perform the CT component with arm ZEP, except for head and neck studies where the arms are placed by the side. So this, I will get on to it because it helps in minimizing the truncation artifacts. The important thing, like in CT, you have the Hounsfield units. Here you have a SUV, which is the standardized uptake value, which is actually gives you indicates the amount of FDG uptake in the region of interest, and that is adjusted to the body weight. So a fat person, it depends. See, you can say that fat person might have more glucose or whatever, you adjust it to per kilogram body weight, unlike the HU where it is actually the photons which are being measured. Okay. And because here there is a metabolic component to it. And this is very useful for standardization and comparison, because if during cancer therapy or even during cancer itself, we require follow-up scans. When you need follow-up scans, weight is going to come low. So and at that time the uptake might be less, but you have to have a SUV, which is a measurable comparable unit. And now I would like to tell you that I would like to now take up the common artifacts which we have and the components which give us the images. Now, a routine image, all of us are quite familiar. It's all familiar with CT. Now, what you're having with PET CT is something that glitters. So it makes you aware that, hey, there's something wrong here. There's something going on here. But what we need to remember is that there can be, as in any other test, false positivity and false negativity. Now, the causes of false positivity or some kind of thing can occur, or some kind of abnormal high reading can occur because of various reasons. One is because of technique, the other is equipment, patient artifact, and we have to remember that there are normal areas of uptake which are physiological. And then you have the pathological artifacts, which I think Dr. Murli will be taking in detail. Now, principle of FDG is, I told you that FDG competes with glucose, and FDG competes with glucose for uptake by membrane transporter proteins. All tissues in the body utilize glucose as the source of energy, and some organs use it more, some organs use it less. During activity, it is very increased, so that's why you have to be in a quiet room. And this is the basic principle of FDG. Okay, in PET, of course, you have other markers which use other metabolic parameters, but we FLT and stuff like that. But here we are going to talk about FDG PET, and so normal tissues with high glucose metabolism can show increase in FDG PET, FDG uptake. And so it is important, hence, to know which sites take the uptake properly. Okay. In order to prevent false negative results, it is necessary for the patient to at least fast for 4 to 6 hours prior to procedure. And you have a euglycemic hypoinsulinemic state to reduce the uptake of glucose by the myocardium and the skeletal muscle. In the fasting state, the decreased availability of glucose results in predominant metabolism of fatty acids by the myocardium. And this reduces the intensity of myocardial uptake and prevents masking of metastatic disease within the mediastinum. Then patient anxiety, of course, they are anxious, but if you allow them to hear some music, or you can have soothing music, but if you allow them to read or something like that, then you are going to have increased activity, and also this can also in general cause activity because of the contraction of the stress around the neck muscles. You can have increased uptake. Then muscle contraction immediately prior to or following injection can cause increased FDG activity in major muscle groups, which is why we allow the patient to relax. So now let me talk one by one about the techniques. I'd also like to tell you that we are having our AOCR as by way of distraction in January 2025, and Chennai welcomes you. So one of the technique is, because you can have injection of a radioactive clot following blood withdrawal into the syringe at the time of radio tracer administration, and this can result in pulmonary hotspots. So what happens in the eluting room? Once you get the medicine, the FDG is required amount is calculated and fed inside the syringe. What can happen is, at the time of radioactive, you can, when you are injecting, you can have a clot. We've seen in when we inject CT also, you can have a clot which will contaminate the thing, and that can go inside the system. And what happens is that can light up, but there will not be a CT correlate for this. And so we should think that this is an injected clot. Okay. However, this is a diagnosis of exclusion. So we have to really look at the CT images to ensure that the increased radio tracer activity does not relate to misregistration of a pulmonary nodule or a hilar nodule. The area of abnormal radio tracer uptake should also be closely evaluated on subsequent restaging CT to ensure there has been no interval development of an anatomical abnormality in the region of a previously diagnosed injected clot. So it is important, because sometimes what happens is PET CT, we all know, is very insensitive to sub-centimeter nodules. But you might see them at CT, you might feel, okay, I'm ignoring it, or you might not see it. Sometimes it might, you might just see this hot area. So once you've seen it, don't forget to mention it in your report that the radioactive hotspot was seen here, but however, there was no metabolic correlate. So this is very important, so that we look at this very carefully. Now look at this. This was an osteogenic sarcoma of the femur, and you can see that there is a hot area here. 1 minute. Point options, 1 minute. Okay. So you can see this hot area here, which is seen in the coronal as well as in this axial images, and a 3-month follow-up CT thorax. However, this is the 3-month. Here we thought maybe it is there, maybe not, kind of a feeling. But however, after 3 months, you cannot see any pulmonary nodules. However, we don't repeat a PET CT so quickly. And of course, if you had repeated the PET CT, in all probability, you would not have seen it. Then we have the common misregistration artifact. As I told you, that CT happens in a single breath hold. You just run through. Now, with the higher types of CT machines, we have the machine just runs through. And what happens is the pulmonary nodules are registered with a lot of accuracy. Now, the evaluation of a pulmonary nodule provides an unique challenge because, particularly if it is in the base of the lungs, because of differences in breathing pattern between CT and PET acquisition method. It is not that the same donor takes the PET CT. It is first the CT is taken, there is a small delay and then the PET is acquired. Okay. So what happens is also the time taken for PET CT is much longer, around 15 to 20 minutes it takes. And you can see that, and it stops at each bed position, head, then chest, then abdomen, and extremities, depending on what you want to do. And that's how the protocol works. So, what happens is PET images are acquired during tidal breathing, and this can contribute to misregistration of pulmonary nodules on fused PET CT images. Misregistration is evident at lung bases, and it can lead to differentiating pulmonary nodules from focal liver lesions. So what happens is, in a PET image, you might see that it is in the liver, whereas actually it is sitting right in the lung. So this was a problem when they were standalone PET CTs. And if it's a small nodule, the low resolution CT can miss this nodule. So you have to really correlate these images. Now here you can see this is a lung nodule. Now, however, the lung was completely clear, and what you can see here is the liver metastasis, which is actually seen. Now, as I told you before, there is a certain amount of attenuation correction. Now, PET CT scanners, patients are usually scanned with their arms at their sides because scanning sessions are lengthy. And also, imagine an older person having a frozen shoulder, it becomes a little difficult. However, in PET CT, patients are scanned with their arms above their head to prevent truncation artifacts. Truncation artifacts are due to difference in size of the FOV between CT, which is 50 centimeters, and PET, which is 70 centimeter tomographs. These artifacts are frequently seen in large patients or patients scanned with their arms down, such as in the case of melanoma and in head and neck indications. When the patient extends beyond the CT field of view, the extended part of the anatomy is truncated, and consequently, it is not represented in the reconstructed CT image. This in turn results in no attenuation correction values for the corresponding region in the PET emission area, hence introducing a bias on the PET attenuation images that underestimates the SUV in these regions. So that is what is truncated artifact. And here you can see a truncated artifact. This is a patient where you have seen the arms are down, and you can see that there are straight lines along because of the way there is a mismatch here. And so non-attenuation corrected images are very important to have a look at it. Okay. Then we have something called also another injection artifact because of leakage of radial tracer into the subcutaneous tissue at the site of injection, or tissue injection can result in subcutaneous. So what you have is actually a small counter or a small bulge which can happen because we know that the venous system in oncology patients are very fragile, particularly after chemo or two. And this can result in spurious uptake in axillary nodes proximal to the injection site. So you must look at all these things. Injection at the contralateral site to the site of disease is always advised where feasible, to allow actually whether it is due to artifact. But because suppose you have a CA breast on the left side, it is good to inject the patient on the right side to avoid this kind of artifact which can occur. The site of injection should be clearly documented, and this should be available to the reader so that you can ensure pathological FDG uptake is not spuriously is attributed to injection artifact, or some kind of uptake that is there is attributed to spurious artifacts. Okay, so here you can see there are some hot areas, but when you look very carefully, these nodes in the CT are not at all significant. Okay, this was a patient who had a colorectal cancer, and you can see that these nodes are not significant. So correlation is very important. Then we have contrast agents. Intravenous or oral contrast agents such as iodine and barium sulfate affect the quantitative and qualitative accuracy of PET-CT, similar to metallic implants. We know that high contrast concentrations result in high CT numbers, and this can cause streak artifacts because of photon absorption. And this increase in the CT numbers also results in high PET attenuation coefficients, leading to an overall overestimation of tracer uptake. So attenuation artifacts can occur also due to extravasated that I've already mentioned. So here you can see this is an extravasated contrast, and it was actually because of the streak artifact. You can see that this is the artifact which you see. You think that it is probably a node, but in the source images or the non-attenuation corrected images, you can see that this does not exist. So then there are a whole number of artifacts which are patient related. Okay, so the other thing is, so here it can be due to artifacts when imaging metal. The presence of metal implants in the body produces streak artifact on CT, which I told you. And the presence of metals, I told you, causes over attenuation and causes hot spots. So the other kind of hot spots that are there are prostheses, dental fillings, indwelling ports, breast expanders, contrast media. All these cause streak artifacts, and they can cause attenuation correction artifacts. So in order to avoid false positives, particularly when imaging implants, you should look at the non-attenuation corrected image, which do not produce this artifact. Some implants attenuate the PET 511 keV photons. So it will be spuriously, it will become a cold area where I showed you the truncated areas. So here you can see that this is the artifact where it is so cold here. This is another one where you're able to see that there is a shoulder kind of, there is a metallic artifact which is there, and you're able to see that this is the hot area which you can see. Then IUDs and stents are notorious for causing this artifact. Here, I'm sorry, I didn't keep the CT. This is the IUD, which is seen here. And this is the CT image where you are able to see the IUD. This is a stent, which is causing a hot area in the region of the head of the pancreas. But actually, when you look at the CT, it is just the stent. So this is how CT has kind of revolutionized how we use metabolic imaging elegantly. Now, physiological FDG uptake include cerebral tissue. Moderate uptake is also seen in liver and spleen. Liver is always more than spleen in normal. There is a general mild uptake in the GO junction. It is also diffuse uptake is common in stomach and salivary glands. Uptake in cecum and right colon tends to be higher than in the remainder of the colon due to presence of glucose-avid lymphocytes. We all know how sensitive lymphoma is to PET-CT. So whenever you have little glucose-avid lymphocytes and metabolically active ones, you're going to get these kind of high activity. Approximately 20% of the isotope is renally excreted in the 2 hour post injection, resulting in intense radioactive activity in the renal collecting system, ureters and bladder. In the ureters, it will be an intermittent uptake or a continuous uptake depending on the urinary peristalsis, as you see in IVE. So they are usually for the bladder, particularly you want to see the rectum, you should, or you want to see the uterus, you must make the patient void before you take. In reproductive cycle, the ovaries are also have an uptake in which is highest during the ovulatory and secretory phases, and it varies. And ovarian uptake is usually seen in mid-cycle. Normal symmetric uptake in testis is seen, and this reduces with age. Then the others are brown fat and adrenal activity. Now let's go to the brain activity. Here you can see FDG brain, because 20% of the total body glucose metabolism is in the fasting state, and it takes up the whole lot of uh, for brain metabolism. It is glucose. Okay, so that is why we need to. It is a area of high activity. And when you compare white to gray matter, gray to white matter, it's 2.5 to 4.1. And the higher areas of uptake are basal ganglia, frontal eye fields, posterior cingulate cortex, visual cortex. So overall, whenever there is a high visual activity, there is increased activity in the brain area. Lower metabolic activity is in the medial temporal cortex. So you can see how this is a very nice area of high activity. One more thing, and this phenomenon of increased activity in normal brain is used when you want to study Alzheimer's or other epileptogenic foci and all that, because those in Alzheimer's or low activity, you are going to have less glucose activity. Okay, so you can see all the normal areas where there is intense activity in the sagittal, coronal, and the axial planes. So, and also it's important to remember that white matter atrophy occurs in healthy aging. So cerebral metabolic glucose inversely correlate with age, and with 12 to 13% between between ages 20 and more than 70 years. So there is a decline in the metabolic activity. So hypometabolism is usually found in the frontal lobes, insula, temporal lobes, and parietal lobes. And least altered are the motor cortex, whereas all these, they will be higher activity. And also the least altered are around in the occipital cortices, precuneus, medial temporal lobes, the hippocampus, thalamus, putamen, pallidum, and cerebellum. So all these areas, as opposed to the previous one, you can see how much the activity is slightly lesser in an aging one. Now, brown fat uptake is basically because of the metabolically active fat. The incidence of FDG uptake in brown fat is 2.5 to 4%. So it is more common in children than in adults, more prevalent in females than in males, because this adipose is a metabolically active one, which helps you to, it is thermogenic, and it helps you to protect against the cold. So it is more frequent in low, thin patients and in colder weathers. Glucose accumulation within brown fat is increased by sympathetic stimulation innervated by the sympathetic nervous system. Giving oral propranolol can reduce the uptake of FDG by brown fat. Maintaining a warm ambient temperature during uptake also reduces brown fat uptake. And it is in a symmetric pattern in the supraclavicular and neck region, and sometimes it can be confused with malignancy. Atypical brown fat can be found anywhere. We've seen them in the mediastinum. They can be seen in paratracheal, paraesophageal, prevascular region, along the pericardium, and in the interatrial septum. Extramediastinal areas include paravertebral, perinephric, perihepatic, and subdiaphragmatic. So in these areas, when you see this area of uptake, you will find that this corresponds to fatty tissue. So then you should think that this is not significant. So it is very important that we look at, be aware of this problem, whenever you look at it. So this is a person who has a brown fat. This is a 48-year-old with a colorectal cancer. It is, you can see there is brown fat in the, there is fat in the interatrial septum, but this is showing extensive activity. Similarly, you can see a supradiaphragmatic hot area, and you can see this is not a node. Okay, this patient had a malignancy, and here you can see this is actually due to a brown fat uptake. And now let us look at the uterine and ovarian uptake. In premenopausal women, endometrial FDG varies cyclically, and it is increased both at ovulation and during the menstrual phase of the cycle. Benign causes also are important, which include recent curettage. In this, I would also like to tell you that bone marrow biopsy in the PET-CT can produce a linear artifact. Sometimes it can be getting confused with a hot area. So any manipulation actually causes PET-CT, FDG artifact or PET artifacts. And besides that, you have benign conditions like fibroids and endometrial polyps. And ovulation, as I told you, has increased ovarian uptake. In postmenopausal women, endometrial and ovarian uptake is like how you would find in a CT or an ultrasound and should be investigated. During this was a patient who had breast cancer, and she had a scan during her menstruation, and you can see actually that there is endometrial cavity, there is some hot area which you can see, and you can also see which is, and that endometrium is actually thickened in CT. Here also you can see it is thickened in CT. I'm sorry for the smaller images. It is really thickened, and actually you can see that. And this was in a 42-year-old woman at a different stage in her menstrual cycle, and this uterine uptake completely disappeared. What was there completely disappeared. Then incidental adrenal lesions are very common, and they have been reported with the positive PPV of 95% and a high negative PPV of 94%. Okay. False positive adrenal lesions include angiomyolipoma, adrenal hyperplasia, adrenal adenomas. And normally, FDG activity is greater than that of liver, is generally associated with malignancy. However, benign lesions also have a greater activity. So FDG uptake, sometimes you have these adenomas and all that, which we normally ignore when we do a CT. These can light up during a PET-CT. So you can also correlate it with HU values of less than 10 or non-contrast for adenomas or fat-containing myolipomata. Symmetrical activity of FDG also shows a benign physiological FDG uptake. Now, this is a symmetrical activity seen in both, and you see how normal both adrenals look. And then post-chemotherapy, 5 months later, you can see the black arrow. You can see that there is marrow uptake. More of this will be told by Murli. So you can, these are the things. Then thyroid uptake. This is a notorious one because it is incidentally and almost 4%. A lot of time with the diffuse pattern in roughly half cases and a focal pattern in the other half. And the diffuse ones are thyroiditis, multinodular goiter, and Graves' disease. Focal uptake is seen in a risk of malignancy from 30 to 63%, which is why a correlation with ultrasound is very important. Last of it, you have the gastrointestinal tract, which is very variable. Low-grade linear uptake is due to smooth muscle activity and swallowed secretions. I've told you saliva material, this FDG is seen there, and more focal uptake is seen in the distal esophagus, is seen in Barrett's esophagus. OGD may be seen, may be done, but typical activity of FDG uptake is of low grade in the stomach, and it has a J-shaped configuration. Small bowel typically shows a mild heterogeneous activity throughout. So you can see that sometimes you have you can have overlapping undistended bowel, and that can also cause increased uptake. And this is FDG uptake is normally seen in cecum, right colon, and rectosigmoid region. And focal areas within the colon that are of greater intensity than background liver should raise the possibility of a colonic neoplasm. Incidental malignant lesions were identified in 19% of these patients with pre-malignant lesions, including adenomas in 42%. So when you're doing CT for something else, you pick up an adenomatous lesion, particularly when you're doing CA breast and all that. These are also associated with some cancer, so colonic cancer. So we have to really keep a watch on these. So I would just like to tell you that you do have a huge amount of artifacts, which are basically because of faulty technique, because of machine related artifact, because of certain amount of artifacts within the patient, like a metallic artifact. Then you also have a whole area of uh, normal anatomy, which gives you the artifact, so which will be dealt with in the subsequent talk. So thank you very much. And just to want to tell you that we will be, this is part of Society of Oncologic Imaging, which is a part of our fora of IRIA. We are very much a partner of IRIA, and we believe that specifically conferences are very important. And I would like to thank IRIA and ICRI for this wonderful opportunity. And we'll be launching also our SOII Academy shortly. Thank you very much. Thank you very much.
Thank you very much, ma'am. It was a wonderful lecture. And before Dr. Sudhir Kale take over, I would like to introduce Dr. Murli. Murli is a consultant at Fortis Hospital and a very good friend, an excellent radiologist, and a dynamic leader of IRIA. So currently he's serving at the capacity of Secretary General at the center headquarters, and he will be talking about the case-based discussions, pulse and pitfalls of the routine practice. This will be part one. He will be also continuing with the part two for additional systemic cases, and he will be enlightening us with the advanced and specific guidelines regarding the reporting and some reporting pulse in the upcoming talk. But let's start with the basics understanding of the case, how to get involved with the identification of pathologies and how to characterize them. Right, Murli? Over to you, Dr. Murli, and the stage is yours. Go ahead.
Thank you, Gaurav, for that wonderful introduction. I hope I am audible.
Yes, you are quite audible. Yes.
Thank you. Yeah. So I think, can you see my screen?
Yes, yes. Screen is visible.
Okay. So I think Dr. Bhagyam has given a general preview of the PET CT, how it is done, what are the the normal uptakes that that you can see in PET CT. So I will straight away go and discuss a bunch of cases that I have. These are regular cases that you would have already seen, but I just want to and also about the newer tracers right now that we have in PET CTs. What all are the new PET CT tracers, and some few pitfalls in PET CT that general mistakes that we make, and how do we differentiate with non-FDG tumors and things like that. So as you know, PET CT has got it initially started off as an primary oncological tool for for baseline staging of the PET, for response to therapy, for evaluation of SPNs, and to look for recurrence or relapse, to guide biopsies and things like that. But then slowly now we have a lot of non-oncological indications in dementias, for epilepsy, for movement disorders, for cardiac viability. And now the most common is that, the pyrexia of unknown origin. Now we get so many of these patients almost every day, where, they're having long, fever for more than 2 weeks with no diagnosis. And PET helps them, guides them at least, in towards a diagnosis. So in primarily, as I said, FDG is the tool for malignancy. Ma'am has already explained the process of how you inject an FDG, how you wait, and then do the scan. Staging of of oncology patients. PET is the modality of choice. This, as you can see, is a patient of Hodgkin's lymphoma. Multiple lymph nodes over the cervical region, into the mediastinum, into the axillary, into the para-aortic or the retroperitoneum, and with a diffuse uptake in the spleen. So, this is a one-stop shop. Now you know that it is a stage 3S, nodes on both sides of the diaphragm with the involvement of the spleen. So, for any systemic disease, especially this staging of, PET-CT helps you in staging of tumors. This is the MIP image, which you can see the entire involvement of the lymphoma. Again, if you can see here, this is a patient actually presented with the lymph node. When you do the PET, you are able to see there is a lesion at the floor of the mouth with cervical nodal metastasis on either side. And but what's interesting is that usually when we have a cervical a cancer in the head and neck, very rarely we will going to screen the whole body. But when we do the PET, we see a small lytic lesion which is involving the vertebra, the dorsal vertebra. So this is a solitary metastasis. Now the staging has changed. What could have been a patient who could have been operated, now he has to go in for chemotherapy or radiation, because now it's a stage 4 disease. You have a solitary bone met, which means it is a stage 4 disease. So again, if you can see here, this is a case of cervical cancer, large mass at the cervical region, but not much of nodes in the pelvis, nor in the retroperitoneum. But then you are seeing nodes in the mediastinum. This is very atypical. But then when the biopsy was done, of the left supraclavicular node, it turned out to be metastasis of the cervical tumor. So though rare, but these things can happen, and that is why we always recommend a whole body PET for any tumor, so that you can stage the tumor properly before starting or initiating treatment. And also, as I said, not only for staging, but also for response evaluation. Especially if you can see here, this is a patient who has had a GIST with multiple peritoneal metastasis. Now, post-treatment, if you have done only the CT, you will see actually these masses are still there. So probably we would say that it is not responding much to the therapy. But when you can actually see that the FDG uptake is gone, almost completely gone, then we know that see the liver lesions also. It usually just metastasis or necrotic even otherwise, but then the FDG uptake is completely gone. The size of the lesion is reducing. Now we can confidently say that the patient is responding to therapy. This is a pre-treatment and post-treatment images. Similar thing, if you can see, this is a case of CA mass in the stomach, but then there is nothing in the lung pre-treatment, but post-treatment we are seeing some uptake in the lung, but then they are patchy uptake, looks like a patchy consolidation, but the primary tumor is responding. So when the primary tumor is responding, very unlikely to have a metastasis. This is actually a infection because of the the patient being immunocompromised. This, if you can see here, patient is called lymphoma, multiple nodes, which has actually responded to therapy. Post-treatment lymphoma, you can see that the nodes has completely resolved. The patient had a lymphomatous deposits in the lung as well. These lung deposits also have responded very well to the treatment. So especially with lymphoma, the mid and last cycle response is very, very important, so that you know how the patient is responding to therapy, and usually they respond very well, and complete disease response is seen with the lymphomas. As I said before, SPNs, we have always had this doubt. This is a little bigger nodule, but then when we do the PET, we know that there is a focal uptake in the nodule in the lung. But also when we see here multiple metastasis, bone metastasis, and nodes which are dicey. But then with the bone mets, we are sure that now we are dealing with a primary lung malignancy, and we are looking at a stage 4 disease. Disease recurrence, again, as I said, this is the case of CA rectum post-treatment. Look at the surgical bed, looks completely normal. But then when we do the 3 months follow-up, we can see now a soft tissue deposit at the pelvic region in the surgical bed. This is a peritoneal deposit recurrence at the surgical bed of a CA rectum patient. So that is why this follow-ups are usually recommended. Now again, CA lung patient, nothing in the lung. Sorry, this was CA rectum again. Patient was treated, patient completely normal. If you can see, there was actually a very, very, very small nodule, indeterminate nodule. Maybe it was missed in the pre-treat, in the screening PET, because there was no uptake in the FDG. Small nodule, they could have called it indeterminate. But then in 2016, patient comes back, huge nodule, which is definitely metastasis, and this patient has progressed. Look at the lung metastasis between 2014 and 16. This is a case of CA esophagus post treatment. So. CA esophagus post-treatment, now we are able to see post-treatment patient was okay, but then when we did the follow-up PET CT, there is a lesion at the patient site where the radiation was given at the mid-esophagus level. We see this focal uptake. Now you know that there is probably a recurrence there. Go ahead and do an endoscopic biopsy, and then patient was diagnosed to have a recurrence again. Biopsy size. Sometimes, we have these huge masses, which is, with lung masses especially, there is a collapsed lung component also. But then when we do the PET, we know exactly. So if you go ahead and do a biopsy from the periphery of this lesion, you will not get a proper yield. So this PET actually helps us to guide the biopsy site. There is focal FDG uptake right here at the middle. Go inside, take the biopsy from this side, and you will get a very good yield. Similarly, if you can see only the CT, huge mass, but you can see the uptake is only here. Now the PET guides us into the biopsy wherever there is, do the biopsy at the site wherever there is increased FDG uptake. Carcinoma of unknown origin is again something that we are picking up recently. Thanks to the extensive medical checkups that we do, we pick up some malignant nodule or a node, and then we try to find out if this is malignant. If it is malignant, where is the primary coming from? So if you can, this patient actually presented with back pain, severe back pain, did an MRI. Then the MRI showed multiple bone mets. Then the patient went in for a PET CT. When we did the PET CT, you can see multiple lung nodules were also seen, extensive bone mets were seen. But then you see the primary focus, very, very focal, small wall thickening at the pyloric antrum. And then patient was done, endoscopy was done, and maybe in CT we wouldn't have picked this up, but you can see this focal uptake in the stomach. When you do the endoscopy, do the biopsy, it's a primary gastric malignancy with extensive lung and bone and even peritoneal metastasis. This again, patients sometimes come present with a huge neck nodal mass, and you do the biopsy of the neck nodal mass, turns out to be squamous cell carcinoma. Now the search for the primary starts. If you can see in this patient, multiple nodes with this huge nodal mass in the left cervical region. Then when we do the PET, you see this focal uptake in the tonsillar fossa. Then we know that this is a primary nasopharyngeal tumor. And then because why it is important is when we do the radiation, you have to cover this region also. When you do the chemo radiation, cover this region, then the response is amazing. If you see in March, the mass is completely reduced, regressed. The primary lesion is completely regressed. This is the effect of chemo radiation, and we can follow up the response of this patient also. Synchronous malignancy is again something that we commonly see, especially when we do these whole body PETs. And we always have to remember that not all are metastasis that we may be dealing, especially old patients, 70 years, 80 years, they usually harbor and are likely to harbor another second malignancy, and we can pick that up as well. Of course, this is a very unique case where this patient had a mass at the tonsil and metastasis, the nodes, cervical nodes at the level 2 region were metastasis. So I was asked to do an FNAC of the cervical node. As I was looking down, I saw some node here also at the level 4 region, and did the FNAC of both the nodes. And interestingly, the histopathology for the first node at the top, level 2 was squamous cell carcinoma, whereas for the node at the level 4 was papillary carcinoma. You can see here actually there is a focal uptake in the thyroid, and if you can see the node here, the enhancement is typical to that of the thyroid. This is a thyroid malignancy metastasis, whereas at the higher level it was a tonsillar mass with the metastasis. So synchronous malignancy within the same cervical region, though quite rare, is something that can happen. And you can see here, this is the enhancement of the level 4 node, whereas the level 2 node showed a different type of enhancement. So now moving on to another part of the PET imaging is the newer tracers. We know for years together, almost now 15 years, we are being using only FDG as the primary tool for PET CT. But then now there are a lot of newer tracers which help in diagnosing in specific type of tumors, and it is good that we know about them so that we can use them in our day-to-day practice, and so that your false negatives are prevented, and also you get better imaging and better response with the newer tracers. So that as I said, FDG was always the primary tumor, the tracer. Now we have PSMA, which is very specific for prostate, DOTA-TED, which is very specific for endocrine tumors and neuroendocrine tumors, and FAPI, which is just which came in as a very good tracer for stromal tumors, but now it is slowly replacing even FDG in many tumors. So as I said, FAPI, it is called fibroblast activated protein inhibitor. And the biggest advantage of FAPI is that it doesn't work on the glucose metabolism. So patients who have high glucose, low glucose, you can still use FAPI for staging of tumors or for diagnosis. And also, there is less uptake in the brain when compared to, or no uptake in the brain, because it doesn't work on the glucose metabolism. So false positive rates are low. It's become a multi-tumor tracer now. And now even in PSMA negative prostate cancers, we can use FAPI. So as I said, what initially started as for stromal tumors, now for sarcomas, esophageal carcinomas, breast cancers, lung cancers, ovarian, pancreatic, whatever it is, I think FAPIs are giving better results or almost equivalent results to that of FDG. And the availability of FAPI is also increasing rapidly in India, and we can use this tracer, as a replacement for even. If you can see here, this FAPI is used for a case of HCC. Usually HCCs very very low or no uptake in FDG, but we can see here in FAPI the uptake is quite high, and it is able to differentiate the necrosis from the peripheral tumor, and this helps us in biopsy and also in the treatment of this patient. Again, it helps us in peritoneal metastasis. Usually FDG in this was a mucoid tumor, but then FDG FAPI is able to pick up the peritoneal metastasis in this tumor. Brain mets, especially sometimes what happens with brain mets is that here of course the intensity is high, but sometimes the intensity merges with that of the brain. You won't pick up the brain lesion, but with no background uptake, you can very easily pick up the brain metastasis. Again, there are lesions where this is a patchy consolidation in the lung, but you can see here this is a focal uptake which is seen in the lung, which is because of the metastasis, and the FDG is not showing this metastasis. Another newer tracer is gallium pentoxy-4. It is used specifically for multiple myeloma. I'm just touching about all these tracers. All these are separate sessions by itself. I just wanted to give you an overview today, and then we will have detailed classes later during the year. Gallium pentoxy-4 is very, very sensitive for multiple myeloma, so it can be used for pre-therapy and post-therapy evaluation. If you can see here, this is multiple myeloma, which is having focal uptake along the bones, but then post-treatment, this uptake is regressing. PSMA, as I said, is the tool for diagnosis of prostate cancers. It is very, very specific. So any uptake in prostate cancer in PSMA, then we can be sure that it is a prostate malignancy with metastasis. Not only that, it helps us, as I said, in guiding the biopsies and evaluating. When we combine it with the MR and fuse it with the PET, you get excellent images, which helps the surgeon in the surgery and also in the chemo and radiation, that the hormone therapy and the radiation that follows for prostate patients. So while the local staging MR is very good, but then the FDG uptake and the bone, distant metastasis, especially the bone mets, is picked up very well by GP. So the most interesting part is that, usually these prostate cancers have very, very small pelvic nodes, and whether these are, nodes which are malignant or not, PSMA is very, very helpful. So once PSMA uptake is there, then you're sure that it is a malignant node, and then then the surgeon extends his surgery and does a pelvic dissection of the nodes as well. Daughter neck PET CT again is very, very specific for endocrine tumors, where PET is usually negative. Daughter neck picks up the uptake, and if you can see a very, very small lesion in the wall of the stomach, FDG negative, but then daughter TET is able to pick up this focal uptake, and this helps us. Patient endoscopy is also very difficult to pick up the small nodule, but then patient had presented with multiple. This again patient presented with multiple liver metastasis. You can see here the liver mets. But the primary is not known. But then when we do the daughter TET scan, the biopsy of the liver showed a neuroendocrine tumor. So they did a daughter TET scan. If you can see a focal uptake, this was a lesion in the jejunum. This was a jejunal and neuroendocrine tumor, and with mets. It is very, very important to identify the primary, because in neuroendocrine tumors, until you remove the primary, the treatment response is very, very bad. So once you know there is this primary here, go ahead, remove the lesion, and response is good. Same thing with you can see a focal brain metastasis for a neuroendocrine tumor patient. You can see the focal uptake, no background uptake like PSMA and FAPI. Identification of brain mets becomes very simple. Extendin, very rarely used again to tracer, but it is very, very specific for insulinomas. We can see, and also in evaluation of pancreatic tumors, because it basically has uptake on the beta cells of the pancreas. So wherever beta cells are there, extendin goes, attaches itself. This is actually not a prime tumor, but this is actually a patient with a pancreatic transplant. So whenever there's a pancreatic transplant in our institute, and we think of some rejection, then we can do this extendin scan, check for the whether there is beta cell uptake. If the beta cell uptake is there, then we know it is working, and there's no rejection. Here, if you can see the CT, no focal lesion you can make out in the pancreas. This patient is having fluctuating glucose levels. The clinician had a suspicion of insulinoma. When we did the extendin, this focal uptake at the head of the pancreas confirmed that it was a case of insulinoma. Go inside, remove this tumor, and patient is completely normal and has no other symptoms. Pyrexia of unknown origin, as I said, is a very, very common condition now, especially in India. People having long-standing fevers, PET becomes a one-stop solution. And so we have if you can see in this patient, very, very small nodes, which were, you cannot call them significant in a CT, but then when we do the PET, focal uptake in all these nodes, look at the subcarinal nodes showing uptake. Then these small nodules in the lung also were picked up. focal lesion in the liver was picked up, and the nodes in the periportal region were showing uptake. Then, the supraclavicular node showed uptake. So the biopsy of the supraclavicular node was done. It turned out to be tuberculosis. Similar here, spine lesion. I mean, this is little typical, but PET helps us to differentiate and do the biopsy and diagnose tuberculosis. And with the diagnosis of tuberculosis, then treatment becomes. Here you can see a focal uptake. Again, patient fever for long, no diagnosis. When we do the PET, focal uptake along the valves of the stomach. This was diagnosed as endocarditis. This patient had a total hip replacement. Almost 7-8 months later, he started developing this fever. The orthopedician suspected it to be, prosthesis infection. Do the PET. This diffuse uptake along the, the prostate, the prosthesis. The prosthesis had to come out, and then the patient, got cured of the fever. Sometimes, patient comes with these type of, sepsis all over the body. When we do the FDG PET, we know that, you can see all the focal uptake within the muscles. These were all septic abscesses within the muscle. Patient presented with diffuse sepsis. In fact, this patient we lost because, such type of patients also, FDG helps us to even give us an extent of the, the extent of infective disease burden that we are actually dealing with. Here, patient presented with pericardial effusion alone. If you can see in CT, not much of a wall thickening, but then PET showing diffuse uptake. That is some registration difference, but actually diffuse thickening along the wall, diagnosed as pericarditis, treated, and patient did well. Again, here, patient, if you can see the CT, not much of wall thickening along the aorta, but then focal uptake along the wall of the aorta. Along the descending aorta, along the thoracic aorta, along the abdominal aorta also. When we did you can see here along the wall. This was then when we did the whole body. If you can see the MIP, you can see the uptake along the subclavians as well. This was diagnosed as a case of aortoarthritis. Sometimes not all FDG uptake nodes are TB. If you can see here, multiple nodes. Especially along the hilar and perihilar. But if you look at the spleen, diffuse uptake with an enlarged spleen, and look at the parenchyma of the lung, multiple nodules with multiple small nodules, which are seen especially along the subpleural region. This was diagnosed as a case of sarcoidosis. The spleen gave it away. Usually, you don't have such huge spleens in TB, but sarcoidosis, it's very, very typical. Sometimes, focal, we casually pick this up, focal uptake on both thyroid nodules. This is a case of thyroiditis. Again, patients with ILDs, we don't know whether these are collapsed lung or consolidation. When we do the FDG, when we see some focal uptake, then we know that the ILD patient actually he is infected, and there's a patchy consolidation at some part of the lung. Shortly on some of the pitfalls that we usually see in treatment in PET is that as we were discussing about the lymphoma, as I said, huge post treatment. When we see this, the CT, there is still there is some sort of residual lesion, but then there is nothing on the PET. So we have to give this as complete response. There is something called the dual scoring, which of course when somebody is talking about lymphoma, they will tell you. But remember that not always, post treatment, the node, the anatomical disease will not be gone fully. But then the FDG is very, very typical. Uptake is very, very classical for post treatment analysis of Hodgkin's lymphoma. If you can see here, sometimes, this thymic rebound hyperplasia is something which is very common post-treatment for lymphoma, or for that matter, any tumors. We should not, mistake it for a disease recurrence. So post-chemotherapy, usually, the thymus, which becomes very small, gets rebounded, and this thymic rebound hyperplasia should not be diagnosed for a metastasis. SPNs, not all SPNs are malignant. So if if you can see this patient presented with SPN, did the PET, there's no uptake at all. It was actually a CT diagnosis. It was a case of a mucosal, but then nobody bothered to do the HU, and they sent for a CT, PET CT, and it was a negative. Absolutely nothing. This is again a 46 years old man post 4 cycles of chemotherapy. But whenever they give chemotherapy, they give this colony stimulating factors. So this, remember, whenever the patient is post colony stimulating factor injections for the thing, there will be diffuse uptake along the bones. And we should not think this is because of the bone metastasis or bone marrow disease in a lymphoma. And this is because of the colony stimulating factors that is given post chemo, especially in lymphoma. Again, CA esophagus post chemotherapy, post radiation therapy. Always remember, radiation will cause some sort of changes in the lung, and we should remember it. And these are post RT changes and not the metastatic disease that is occurring in the lung. We can see this focal packets and acute ground glass changes that is consistent with acute radiation changes in the lung that happens post RT. Infection, again, whenever there is a bone marrow suppression post chemo, that is, patient is prone for infection. If you can see, there is this focal wall thickening and fat standing around the ileum. Some node is also there. We should always, this was actually consistent with typhlitis, and it is very common in a patient post chemotherapy. Always remember that in mind. Post surgery on the post chemo also, there is uptake for at least a few weeks, and we should not confuse it with residual disease. Give it its time, usually 6 to 8 weeks, and then do the FDG PET, and we can see the response. Even talc pleurodesis, this is something patients with malignant pleural effusions, they go in, strip the pleura, inject talc, and usually talc is somehow FDG positive because of and we should not confuse it with pleural disease that is existing there. It is because of the talc that is seen at the surface of the pleura. NHL patients, again, post chemotherapy patients are known for osteonecrosis, and these type of osteonecrosis can also show some vague sclerosis, and it will show a focal uptake. So it is difficult to actually do a biopsy of these patients, but always remember in my mind that not all focal sclerotic lesions are metastasis. They can also be osteonecrosis, and if always keep that mind in your brain that it cannot, not all, everything could be metastasis, and give it its time, and we can see if this patient is healing post the therapy. Again, especially if you give patients with insufficiency fractures also is known to have this type of focal uptake, and often confused with metastasis. Look at the other response evaluation, and if there is if the entire primary tumor is responding, only one this lesion, already a sclerotic lesion, now it is become like you are seeing a soft tissue component. Then also remember that insufficiency fractures are also quite common because of the the osteopenia that happens in the bone. And look at the site of the of where the uptake is. Usually, in it is not a very common site for metastasis, but a very common site for insufficiency fracture. Give that a consideration as well. This was a case of sarcoidosis. Again, as I told you, remember, not everything is lymphoma. I'm just or TB. Give this look at the spleen. Look at this typical uptake in the mediastinum, which is very classical for sarcoidosis. Again, this was a case of laryngeal carcinoma treated, but then this focal nodal uptake, they thought it was metastasis. Then when we did the biopsy, it turned out to be sarcoidosis. Similar with LCH, very often you confuse them with the metastasis or with some other primary lung disease, focal lytic lesions, or focal hypodense lesions in the liver. LCH is also something which you always remember in mind. So as I said that not all PET tumors are positive. There are so many PET tumors which are not have FDG uptake, like the bronchoalveolar carcinomas, carcinoid tumors in the lung, RCCs, mucinous tumors in the GIT and colon. So that is why we are having so many different traces. But always, and when we are having only doing FDG, which is the most common, always look at the CT and always consider diagnosis of other diagnosis. If you can see, this is a typical mass. You can see a lower pole of the left kidney, but no uptake, because RCCs are usually low FDG uptake. And you should not think otherwise. And this is you have to remember your CT and call it an primary RCC. Again, mucinous was a ductal carcinoma. So you see here, this is a typical ductal carcinoma, focal lesion, intense FDG uptake, no problem at all. But if you move to the mucinous tumor, this also in CT wise, you would have called it a malignant lesion. But when you do the PET, no uptake at all, then always you should consider the diagnosis of a mucinous malignancies, because they have low FDG uptake. Similar here, if you can see here, this is diffuse peritoneal disease, but no primary lesion. When we do the biopsy of the peritoneum, it turned out to be a primary mucinous tumor of the peritoneum. So that is why the FDG uptake is also very low. But always have this high suspicion for mucinous tumors when the FDG uptake is low. This is a patient, with chronic hepatitis. Patient actually case of CF breast. Now this is a focal lesion in the liver, but arterially enhancing lesion, and no FDG uptake. But then when the biopsy was done, it was actually a case of hepatocellular carcinoma. Again, HCCs have very low uptake in PET-CT. Osteoblastic metastasis, usually sclerotic metastasis, usually seen in advanced breast cancers, and not like the osteolytic lesions. Osteosclerotic lesions usually have very low FDG uptake. So, like if you can see these multiple small sclerotic lesions. The only problem is whether these are primary active sclerotic metastasis or non-active post lytic lesions which are becoming sclerotic. If you have a follow-up PET, then it's not a problem, but otherwise you cannot differentiate. But then for all practical purpose, you have to call them as sclerotic metastasis from the primary breast tumor. So in conclusion, PET, as I said, has got a lot of oncological and non-oncological indications, modality of choice for cancer staging and response, one-stop shop for cancers of unknown origins as well as pyrexia of unknown origins. Now several traces are available. So not only should you know about these traces, you should also start using them and tell your referring consultants also about these traces. And not always all, as I said, as Madam has said, not all that glitters is gold. So not all uptakes are malignant or positive. And at the same time, not all those which you don't have FDG uptake also doesn't mean there are benign lesions. So you should always use your clinical acumen and your CT knowledge so that you come to a proper conclusion. So thank you so much, the Gujarat chapter of IRIA and SOII for giving me this opportunity. Gaurav, thank you. Pankaj, hi.
Hi. Excellent talk, Dr. Murli and Dr. Bhagyam. And on behalf of SOII and Gujarat State Chapter, we are extremely thankful to both for providing us the basics and telling us in detail about modality. Dr. Gaurav, are you there?
Yes, sir, I'm here.
Yeah,
Thank
yeah.
you very much.
I will hand over to Dr. Gaurav now.
Yes, sir. Thank you very much, Dr. Murli and Dr. Bhagyam. As always, both of you are one of the finest radiologists to whom we look for learning and engaging for the PET-CT and PET-MR imaging. Again, I would like to thank Society of Oncoimaging, Dr. Sudhir Kale, to take up this collaboration with our state chapter, and we did it very well. Sagar, are you there? I just want to announce one more upcoming event of our
Yes, sir.
Gujarat State Chapter, that we are coming with Dr. Harnam Singh conference on 21st and 22nd of September at Statue of Unity. Sagar, can you please show the... Yes. So this will be at the Fun Sardar Sarovar Resort, and we are coming up with the neuro and spine imaging with starting from basics to the frontier. So each attendees, I would like to request you to register, and abstract guidelines are already there in the flyer. We will be pushing you on individual email. So you can register for your abstract submission for the poster paper, and we are eagerly waiting for all of you. Again, I would like to thank on behalf of IRA Gujarat State Chapter. Over to Dr. Sudhir Kale. Anything specific questions, Sagar, we have right now to the faculties?
No, there is no such comments yet.
I'm sure they have explained in such a way that there will not be any question.
All they didn't
Uh,
understand.
Yes, we will be keeping Murli and Pankaj sir busy during this entire SOICON events, and definitely Dr. Bhagyam will be guiding us from the expert point. Dr. Sudhir, over to you again. Thanks a lot from IRA Gujarat State Chapter to all the eminent members of Society of Oncoimaging. Thank you again.
Thank you, Gaurav. And I think like this was your idea actually to bring in and push in, like get academic events into SOI as well as collaborate with IRIA. I mean, so we are actually very happy to make a kickstart of this event, and with none other than our eminent speakers and experts, Dr. Bhagyam and Dr. Murli Krishna. And it was really wonderful to listen you. I mean, madam, that today we actually, it was a good, nice start with principle and learning artifacts and what normal uptakes, especially the brown fat ones, which keep confusing. And then followed by Dr. Murli's very methodical case-based approach. I think very nice, and nice to see those, especially a few of the cases with quite interesting what we see, like the tonsillar carcinoma and papillary carcinoma thyroid coexisting together, and a lot of lymphoma pre and post treatment scans and all. I mean, it was really enlightening. And followed by, I think you took a list of the indications of like not only FDG PET, but also about the other forms of PET which have come in today's era, like FAPI, then pentaxifer, and also on the DOTA PET, PSMA PET. I mean, all these things, I think it would have definitely benefited to all the delegates here, all the residents, all the junior radiologists. Definitely, it was a very good insight. So all in all, I think a great start, and I think more than 100 people today's attendance here for the today's webinar. Over to you, Pankaj sir, for the final comments.
Thank you all the delegates who have joined this program, and we will request both Dr. Bhagyam, Dr. Murli, and Dr. Sudhir for informative SOI academic activities soon. Thank you.
Thank you very much, everyone.
Thank you, everyone.
Bye.
Thank you.
Thank you for the delegates. Thank you.